evidence-based data with regards to myasthenia gravis, because I know there is a lot of information that is available online, and it becomes really hard to identify what is real and what is not. I'm not saying everything that's available online is false, but then this talk is primarily aimed to provide scientific data so that you know what exactly you're dealing with. Okay, so before we get started, I just wanted to give a quick introduction about myself. So I am a board certified neurologist with subspecialty training in neuromuscular medicine. I did my residency here locally at Harbor UCLA, followed by fellowship in neuromuscular medicine at WashU in St. Louis. Currently, I'm a neuromuscular expert at UCR Health Multi-Specialty Clinic in Riverside. And then I just wanted to give you a quick introduction about what exactly is neuromuscular medicine. So when you think about neurology, the first thing that comes to mind is brain. And for the most part, you're not wrong when you think about neurology being associated with brain, because vast majority of neurological conditions, such as strokes, seizures, Parkinson's, or Alzheimer's, they all occur inside the brain. So for the most part, that is right. However, neurology has two main categories. You have the central nervous system, which deals with conditions of the brain and spinal cord. And then you have peripheral nervous system, which deals with everything outside of brain and spinal cord, which would be typically the nerves and the muscles. As a neuromuscular physician, I typically deal with the conditions outside of brain and spinal cord, which would be, as the name suggests, nerve and muscles. All right. So the diseases that I commonly deal with would be the diseases of the nerves and the muscles. So trying to give you a quick crash course on neuroanatomy here, once you have signals coming from the brain, they're transmitted down to the muscles through the nerves. So you have the nerves that eventually end up at the muscles. There are these specialized areas called the neuromuscular junctions that help in transmitting the electrical information from the nerves and transmitting it into muscles, which ends up in a mechanical form. So these neuromuscular junctions play a very critical role in transmitting information from the brain all the way down to the muscles. So the common conditions that I treat are the diseases of the nerves, which are commonly called as neuropathies. Of these, peripheral neuropathy is by far the most common entity, which is frequently seen in folks who have diabetes. I also treat acquired neuropathies such as carpal tunnel syndrome, radiculopathies, and ALS. And then I do deal with some of the inherited neuropathies, Charcot-Marie tooth disease being the most common form. I also take care of diseases of the muscles, such as the different myopathies, like inflammatory myopathies, congenital myopathies, and muscular dystrophies. And finally, I also take care of conditions that occur at the neuromuscular junction. There are different disorders in this category, but myasthenia gravis, which is the topic for today, is by far the most common form. Okay, so let's dive into the topic for today. So myasthenia gravis, it actually comes from Greek and Latin literature, and myasthenia stands for muscle weakness, and gravis is grave or severe muscle weakness. It was initially identified as a separate disease entity by Thomas Willis way back in 1672. Subsequently, Samuel Wilks identified the pathophysiology behind myasthenia. And then Erb and Goldflam detected and identified and discussed the phenotype of myasthenia gravis. And for a long time, this disease was known as Erb-Goldflam disease. Eventually, Frederick Jolly in 1895 coined the term myasthenia gravis, and ever since then, it's been known as myasthenia gravis or MG. So why exactly are we discussing myasthenia today? The reason is it is one of the most common disorders that can occur at the neuromuscular junction. The incidence or the number of new cases per year for myasthenia is ranging from 7 to 23 cases per million. And the prevalence, which is the number of existing cases, ranges from 70 to 320 cases per million. The prevalence interestingly has been increasing since the mid-20th century. And this is primarily due to the aging population, better identification techniques, and better management strategies. So what exactly is myasthenia? So myasthenia is a chronic autoimmune neuromuscular disorder. The reason I've highlighted these terms in red is mainly because I want to emphasize the importance of these terms. Myasthenia typically causes weakness in the skeletal muscles. So normally in our body, we have three different kinds of muscles. You have the skeletal muscles that help with limb movement and breathing. Then you have cardiac muscles that help in your heart beating normally. And then you have smooth muscles that primarily involve the gut. Myasthenia, interestingly, affects only the skeletal muscles in your body, which is the muscles in the limbs and muscles that help with breathing. The weakness typically worsens with activity and improves with rest. I will elaborate on this in the upcoming slides. But when you look at myasthenia in general, it can occur at any age, but it does have a bimodal distribution. By that, I mean there are two peaks at which the myasthenia can occur more commonly. So there is an early peak, which is in the second or the third decade, where there is slight female predominance, and then there is a late peak during the sixth or eighth decade, and there is slight male predominance. Interestingly, in 10 to 15% of the cases, myasthenia can occur during the teen years. So that's described as juvenile myasthenia. And then you have neonatal myasthenia, that is a result of passive transfer of the maternal antibodies through the placenta to the child. And then finally, there is a very rare form of myasthenia called congenital myasthenia, which is not autoimmune. In fact, it is a result of mutations and different genes that can contribute to myasthenia gravis. However, this form is very rare. So let's look at the pathophysiology behind myasthenia. So there are two main arms that can cause myasthenia gravis. First, it could be antibody related, and second, it could be related to abnormalities in the thymus gland. So if you're looking at the antibody related myasthenia, this is what happens in a normal neuromuscular junction. So you have signals that get transmitted down the nerve, and the nerve terminals, they release a chemical called acetylcholine. These molecules are attached to the specialized centers on the muscle called the acetylcholine receptors. And once these molecules attach the receptors, they send out signals in the muscle, which helps in muscle contraction. So that's how you generate a response at the neuromuscular junction. Unfortunately, in myasthenia, these patients have these harmful antibodies that are floating around in their blood, which interrupt the binding of these molecules to their receptors. And because of that, the signal doesn't get transmitted from the nerve to the muscle, and the muscle is not able to contract. So clinically, this manifests as someone presenting to you with weakness. So that's the pathology behind antibody-related myasthenia. Thymus can also cause myasthenia, and I'll discuss about the details of thymus pathology in the upcoming slide. So looking at the antibody-related myasthenia, again, we have to understand the concept of autoimmune disease. So an autoimmune disease is a condition where the immune system mistakenly attacks itself. So these are the antibodies which all of us have floating around in our blood. And the role of the antibodies is to attack any foreign organism, just like bacteria or viruses that enter our blood. As soon as they enter, the antibodies are supposed to destroy them. Unfortunately, in folks who have autoimmune disorders, such as myasthenia, these antibodies end up attacking your own cells in case of myasthenia at the level of neuromuscular junction. And because of that, the communication between the nerve and the muscle is interrupted. Normally, when the electric signal travels down a nerve, the nerve endings release a chemical which we discussed earlier, the acetylcholine, and it is supposed to bind these specialized centers on the muscle membrane, which is known as the acetylcholine receptors. However, so this is again trying to compare normal and abnormal. So normally the binding of these tiny acetylcholine molecules to the receptors would generate a contraction at the muscle, and you would see this response at the level of the muscle. In myasthenia gravis, however, the receptors are damaged, and because of that, no matter how much chemical is being released from the nerve terminal, because there are no receptors to absorb those chemicals, you do not generate a muscle response, and the response, if you check at the level of muscle, is flat. So I hope everyone's clear with regards to the pathophysiology behind myasthenia at the level of neuromuscle junction. So there are several antibodies that have been detected over the years, but by far the most common antibody that's found in myasthenia is the acetylcholine receptor antibodies. Some other muscle membrane proteins have been more recently identified. The second most common antibody is a MuSK antibody, and then a few newer antibodies like LRP4, agrin, rapsin, and titin have been recently described, but they are very rare. Moving on to the thymus gland, normally thymus controls the immune function in the body. So looking at the anatomy here, just to orient you guys, this is the heart. These are all the major vessels coming out of the heart. This is the windpipe, and then this is the thyroid gland. Thymus gland is this huge thing which sits right underneath the thyroid, and it lies in the anterior part of the chest. Thymus normally grows until puberty and then gets smaller and is replaced by fat. Unfortunately, in majority of myasthenics, they're known to have thymic abnormalities. About 60 to 70% of them have thymic hyperplasia, which is increased cellularity of the thymus gland, and about 10 to 12% of them have malignancy of thymus known as thymoma. The disease often improves or disappears after thymectomy. So although there is no causal data from between thymus and myasthenia, the fact that most myasthenics have thymic abnormalities and their myasthenia improves after thymectomy, there is a strong association between thymus and thymus gland and myasthenia. Okay, with that, we'll move on to the clinical features of myasthenia gravis. So the clinical hallmark for myasthenia by far is the fluctuating pattern of fatigable weakness. I highlight fluctuating here because the weakness or the fatigability typically worsens with exercise and improves with rest. So a typical myasthenic that presents to me in the clinic will complain of specific muscle weakness rather than a generalized fatigue. It's very important to tease out the differences between these two terms because weakness can sound like fatigue and vice versa. But usually someone who has generalized fatigability, they will complain of tiredness, lack of energy, and lack of energy to initiate any kind of activity. That could be systemic, that could be related to anemia, dehydration, lack of sleep, or even depression. So that's not myasthenia. A myasthenic would complain of weakness in their eye muscles or weakness in their jaw muscles or even weakness in their limb muscles, which is very episodic. The weakness comes and goes. The weakness is worse with activity. And once they get some rest, the weakness should improve. That's what you would expect to see in someone with myasthenia. Based on the clinical phenotypes, myasthenia has been divided into several types. You have ocular myasthenia, which is by far the most common type of myasthenia. Then we have bulbar myasthenia, which is secondary to weakness of the jaw muscles. Then there are a few rare forms, which is axial or limb onset myasthenia, which involves the trunk muscles or the limb muscles. And then finally, you have myasthenic exacerbations or flare-ups, which are termed as myasthenic crises. Interestingly, the character Sleepy in The Seven Dwarfs was created by Walt Disney after one of his friends was diagnosed with myasthenia. So this is basically a depiction of someone with myasthenia gravis. Looking further into the clinical manifestations, earlier in the course, myasthenic symptoms are transient. So patients frequently endure symptom-free periods, which would last for hours, days, or weeks. The symptoms, however, gradually worsen and then become more persistent. And later on, patients develop new symptoms, which could develop weeks or months into the disease. The severity of weakness, as we discussed earlier, fluctuates during the day. Typically, the symptoms are least severe in the morning because the patient has rested all night, so they feel pretty strong waking up in the morning. But as the day progresses, the symptoms get worse, especially after prolonged use of affected muscles. So if you think about it, of all the muscles in your body, you frequently use your eyelid muscles because you're blinking a lot and your jaw muscles. And then you also use your respiratory muscles because you breathe. So all of these muscles are at a very high risk of developing weakness in someone who has myasthenia. Overall, the course of the disease is very variable, but it is usually progressive. So based on the different patterns of myasthenia, clinicians have divided the clinical manifestation into 3 different phases. First, there is an active phase where this disease is most active with most amount of fluctuations, and patients typically have most severe symptoms during this phase. This typically occurs within the first 5 to 7 years of onset, and most myasthenic crises or flare-ups occur during this period because the disease is active. This is followed by a stable phase where the symptoms are stable and persistent, but the only time the symptoms would worsen is when someone has an infection or alteration in their medications. Ultimately, the disease reaches a burnout phase where the remission occurs and patients become symptom-free if whether they are on medication or they are off medication. So this is the final stage of myasthenia. So looking at the types of myasthenia, especially the ocular myasthenia, it causes weakness of the eye muscles. So if you're looking at this animation here, when the person is looking straight, the eyelids look normal, then you have them look up for 30 seconds to a minute and the eyelid starts drooping. So that's called ptosis. This is another example of someone with ptosis on the affected eye. When they're looking straight, the lids are symmetric. When you have them look up for 30 seconds, the lid starts drooping. So this is very classic finding for someone with ocular myasthenia. Because there is also misalignment of the 2 eyes, patients frequently report seeing double and seeing blurred. So that's termed as diplopia. And this is an example of how patients describe seeing images, where they commonly describe seeing overlapping images. Of all the kinds of myasthenia, ocular myasthenia is by far the most common type, and it occurs in greater than 50% of the population. And interestingly, more than 50% of patients with ocular myasthenia will develop generalized disease within the first 2 years. Many patients who do not have ocular symptoms at the time of onset will eventually develop ptosis and diplopia at some point in the disease process. I know we discussed about different antibodies that could be detected in myasthenia. However, patients who have ocular myasthenia, the most common antibody that's detected is the acetylcholine receptor antibodies. So next time you have someone who claims they see double, please think about myasthenia gravis as one of the possibilities. Moving on, you have bulbar myasthenia, which is basically weakness of facial, jaw, or the oropharyngeal muscles. Typically, these patients walk into the clinic looking like this, where they use their hand, they use their index finger to prop open their eyes, and they use their thumb to elevate their jaw because these patients develop jaw drop from jaw weakness. They also develop something called dysphagia, which is difficulty swallowing. The classic story you get is someone who is normal when they initiate a meal, but halfway through their meal, they develop jaw weakness, because of which the meal time gets prolonged. Interestingly, because of the jaw weakness, they also have difficulty swallowing, and they end up having coughing spells or choke on big pieces of meat. Patients also develop dysarthria, which is impaired speech. And the classic story you get is someone who starts a phone conversation with their loved ones, and about 10 to 15 minutes into the phone conversation, the person opposite can no longer understand what the person is saying, mainly because they start slurring. When you see them in the clinic, they often have a nasal speech or a hypophonic speech, primarily due to weakness of the palate. And as I mentioned, bulbar myasthenia can also cause some facial weakness. Patients typically develop something called a myasthenic snarl. So this is someone who at first glance looks normal, but when you have them smile, as you can see, the smile looks different. What happens in myasthenics is when you ask them to smile, the upper lip elevates normally, but the sides of the lips, which is supposed to move sideways during a smile, does not move because of the facial weakness. So they are still able to smile, but the smile does not look normal. Bulbar myasthenia is the second most common type, and it occurs in about 15% of myasthenics. And it is very commonly seen in folks who have myasthenic exacerbations, so especially myasthenic crises. And again, of all the antibodies that are detected, bulbar myasthenia is frequently associated with MuSK antibodies. So next time you have someone complaining of jaw drop or jaw weakness, I want everyone to be thinking about myasthenia. And then you have a rare type called the axial or limb onset myasthenia, which, as the name suggests, involves the limbs and the neck muscles. There is something called dropped head syndrome. This is primarily due to weakness of neck extension. Typically, patients who have myasthenic exacerbations also have neck flexion weakness. And then if you look at the limb weakness pattern in myasthenia, it is typically proximal. So we are talking about weakness in the shoulder muscles and weakness in the thigh muscles. And very frequently, the weakness is symmetric, which means it's equal on both sides. We do see weakness at the level of fingers and at the level of feet, but it is not as common as the proximal symmetric pattern of weakness. And as I discussed earlier, this is a rare form of myasthenia, and it can be seen in up to 10% of patients with myasthenia gravis. And then finally, we have myasthenic crisis, which is basically an exacerbation of someone with myasthenia gravis. This is one of the most serious and life-threatening complication of myasthenia gravis, primarily because this involves weakness of respiratory muscles in addition to the bulbar muscles. So if you think about it, someone who has bulbar muscles and they're having a meal, they are at a very high risk of aspirating, not only on the food, but there is a risk of aspirating on their own saliva. If the respiratory muscles are functioning normally, you have the ability to cough it out. But because myasthenics have weak respiratory muscle function, they are not able to do that, and the aspiration leads to severe complications such as aspiration pneumonia, which could spiral down into sepsis. So for that reason, myasthenic crisis is considered to be very serious. This can occur in about 10 to 20% of myasthenics. It typically occurs in the first few years of the disease process, mainly because that's when the disease is most active. It can also occur as an initial manifestation in 20% of myasthenics. I very clearly remember a patient of mine who was 95 years old, who was admitted to the ICU because of shortness of breath and ended up getting intubated. And it was at that age that she was diagnosed with myasthenia for the first time. So she survived 95 years without any myasthenic symptoms. And eventually, at the age of 95, she developed a myasthenic crisis. So just shows you that the disease can occur at any age, and myasthenic crisis can be an initial manifestation in some cases. As we discussed, myasthenic crisis can occur either spontaneously or can be precipitated by events such as surgery, infection, or medication. So this is how patients describe feeling when they go through a myasthenic crisis. Basically, they not only have difficulty breathing, but they have difficulty moving their limbs, and they also have visual abnormalities. So it's really crappy to go through myasthenia crisis. Moving on to diagnosis. Again, I cannot emphasize this enough. History and physical is by far the most important aspect of diagnosing myasthenia, especially when someone presents to me in my neuromuscular clinic for evaluation of myasthenia. I especially dedicate several minutes in just getting a detailed history and performing a detailed exam just to make sure that this is exactly what we are dealing with. To some critical elements on the history that I pay attention to would be the fluctuating pattern of weakness. And on physical exam, the key aspects that I pay attention to would be weakness involving the eye muscles or the facial muscles or the jaw muscles. So history and physical is very critical in the diagnosis of this entity. There are a couple of bedside tests which are also helpful in diagnosing myasthenia. There is this ice pack test, which basically involves using an ice pack. So say you have a patient who has droopy eyelid on one side, you apply an ice pack for say about 2 minutes to 5 minutes, and then you should be able to see an improvement in the lid lag. So this is pretty diagnostic for myasthenia gravis, and it's one of the easily available bedside tests. There is also something called single breath count test, which I routinely use in the clinic setting. For this particular test, we have the patients take a deep breath and count from 1 through 40. A normal individual should be able to count anywhere, any number over 20, but most myasthenics are not able to count beyond 10. So that's how you know that the myasthenic person has a respiratory involvement. Blood testing is helpful, and as we discussed earlier, we typically look for the two most common antibodies, which are the acetylcholine antibodies and MuSK antibodies. Then I routinely do this procedure called electromyography, or which is also known as nerve test or EMG nerve conduction study. So this test has two parts. The first part, we use a small amount of electrical stimulation, and we zap a couple of nerves in the arms and legs. And for the second part, we use a tiny acupuncture needle and test a few muscles in the arms and legs. And this particular study, the electromyography, is pretty diagnostic when it comes to diagnosing myasthenia gravis. And in some cases where you suspect thymic abnormalities, imaging is very helpful. It could be either a CT scan or an MRI scan. So here we are looking at a cross-section of someone's chest with myasthenia gravis. And as you can see, looking at the arrow here, it's pointing towards a huge mass sitting in the anterior chest wall, and this is a thymoma. So all of these could aid in diagnosing myasthenia gravis. Moving on to treatment, again, there are several modalities available to treat myasthenia gravis. I frequently tell patients that when it comes to choosing a drug for treating myasthenia gravis, sky is the limit, because over the years, we've identified several agents which can be used to treat myasthenia gravis. But by far, the most commonly used first-line therapy for treating myasthenia gravis is mestinon or pyridostigmine. This is primarily used for symptomatic management. The good thing about mestinon or pyridostigmine is it kicks in within 10 to 15 minutes, and the effect lasts for about 4 to 6 hours. So if you have someone who comes to you with a droopy eyelid or seeing double, it's very easy bedside test to start them on mestinon, and within 10 to 15 minutes, you'll see both the symptoms improve. And the good thing is it lasts for about 4 to 6 hours. So most commonly, I have patients on this particular drug 3 times a day, because you start taking it first thing in the morning after breakfast, and then 4 to 6 hours in, you're due for your next dose at lunch. And then again, 4 to 6 hours later, you're due for the final dose at the end of the day. There are a couple of other agents which have a very rapid onset. Unfortunately, they are short acting, and we reserve these therapies for someone who is going through a myasthenic crisis or a flare-up. And typically, we use plasmapheresis and IVIG. Both of these agents are very easily available in the ICU setting. So if you have someone in myasthenic crisis in the ICU who's intubated, we could either try plasmapheresis, which is a procedure to remove harmful antibodies in the plasma and replace with good plasma. Or you could use IVIG, which is a concentrated infusion of antibodies that binds to myasthenia-causing antibodies. So there is no right or wrong answer to this. Both of them work really well. So based on the availability at the center that you are at, you could try either plasmapheresis or IVIG. But more routinely in the clinic setting, we always use chronic immunosuppressive therapies. The most commonly used first-line therapy in a clinic setting would be corticosteroids. But because you cannot put someone on corticosteroids lifelong, given the side effect profile, we frequently switch patients to steroid-sparing agents once the disease stabilizes. Some of the steroid-sparing agents that we frequently use are azathioprine, mycophenolate, tacrolimus, eculizumab, and rituximab. And in selected cases who do have evidence of thymic abnormalities, especially thymoma, surgical management, doing a thymectomy, has been proven to be helpful. The reason I have highlighted these two agents, mestinon and corticosteroids, is primarily because We use this very routinely in our clinic setting. And the mode of action for both of these agents is very different. So the example I give to all my patients to understand the mechanism of action of both of these agents is, think you have a pneumonia. So pneumonia is nothing but infection of the lungs, right? So if you have an infection of the lung, you will automatically develop fevers. So there are two ways you can treat this. Either you can take Tylenol, which is only going to treat your fevers, but is not going to do anything about the pneumonia. Or you could take antibiotic, which is not that helpful with regards to fevers, but it can definitely get rid of the infection or the pneumonia. That's exactly how Mestinon and corticosteroids work. Mestinon is like Tylenol. It is only going to treat the symptoms of myasthenia, but it does not do anything about the underlying disease. Corticosteroids, on the flip side, they actually treat the disease, which is the myasthenia. So very frequently, we use a combination of Mestinon and corticosteroids to treat the disease. I hope everyone's clear on this part. So this is what most patients describe as feeling when they take Mestinon. They frequently feel crappy before they take Mestinon, but as soon as they take the medication, it's an oral pill. Within a few minutes, they feel like the system has turned on magically. So it's a very helpful drug in symptomatic management, and it's also a very useful bedside tool to make a diagnosis of myasthenia. Looking at current research, not that we have limited drugs with regards to myasthenia, but there's always push to identify better regimens, which is helpful for faster recovery in patients with myasthenia. So currently, vast majority of research has been focused on B-cell targeted therapies. There are several agents that are currently in the trial. You have inebilizumab, which was previously tried in treating multiple sclerosis subtype, the NMO spectrum disorders. Then you have rozanolixizumab, mezagitamab, and rituximab. Again, all of these agents are currently in trial. However, there is some promising data coming out of inebilizumab and rituximab. So hopefully most of these drugs would be FDA approved in the upcoming months, if not years. Finally, I would like to wrap it up with discussing about the prognosis of myasthenia. So overall, the prognosis of myasthenia is very favorable, especially due to recent advances in early detection modalities, intensive care therapies, and immunotherapies. So myasthenia, which was once considered a severe or even fatal illness, is now effectively treated with minimal long-term morbidity. So typically the mortality is less than 5%, which is huge for any disease. And most myasthenics now have a normal life expectancy. There is definitely a subtype of myasthenia which still succumbs to the disease with higher mortality and morbidity. So some of those cases do have evidence of either a thymoma or refractory generalized myasthenia, or folks who are elderly with complex comorbidities. So unfortunately, these are the ones who succumb to the disease, but vast majority of them have normal life expectancy. I think this is my last slide. These are some of really good resources that I would highly recommend if you want information on myasthenia gravis. MGFA, the Myasthenia Gravis Foundation, is really good resource. Locally, the MG Foundation of California is very helpful. I know there are several Facebook groups or support groups that are discussing about this disease and newer therapies that are going to be available soon. But if someone is interested in clinical trials or enrolling into research projects, then clinicaltrials.gov is an excellent website where you could just log in and get information about ongoing research trials, not just for myasthenia, but any medical condition that you may have. So these are some of the excellent researches that are, or resources that are available out there. So again, this is a slide summarizing all the different manifestations of myasthenia, but I'll be happy to take any questions if anyone has any.
All right, thank you so much, Dr. T. At this time, there's not too many participants, so I think it would be a great opportunity. If you'd like, you're welcome to unmute and ask a question. Or if you don't want to speak up and ask questions, you can also enter them in the chat. So Bernice, yes, this was recorded, and give me a day or two, but it will be up on definitely Facebook, and it will also be on our YouTube account.